Sciatica is an musculoskeletal disease condition. Look at this picture shows that sciatica nerve compression cause pain radiated to leg. Look at this. Then X-ray to check for bone abnormalities. Look at this, spinal abnormalities. Then CT scan. If MRI is contraindicated, next MRI scan. Look at this disc prolapse at L4 and L5 level. Compress sciatica nerve. A detail going on. Introduction. Sciatica is a common neurological condition that results from irritation or compression of the sciatic nerve, the longest and thickest nerve in the human body. It originates in the lower back and extends through the hips, buttocks, and down each leg. The condition is characterized by pain that radiates along that pathway and is often a symptom of an underlying spinal issue such as a herniated disc, spinal stenosis, or degenerative disc disease. Definition. Sciatica refers to pain radiating along the pathway, the sciatic nerve, which branches from your lower back through your hip and buttocks and down each leg. Typically, sciatica affects only one side of the body. Etymology. The term sciatica originates from the Greek word SCIATICOS, meaning subject to hip pain, which itself derives from ischion, hip joint. It entered late Latin as sciatica, referring to pain in the hip or thigh, and was adopted this Middle English from Old French. Epidemiology. Sciatica affects approximately 10% to 40% of population at some point in their lives, with the highest incidence occurring between the ages of 30 and 50 years. It is more common in individuals with sedentary lifestyle, obesity, or occupations involving heavy lifting or prolonged sitting. Types. Sciatica can be classified into following types. 1. Acute sciatica. 1. Sudden onset. 2. Short duration less than 6 weeks. 3. Often resolves with conservative management. B. Chronic sciatica. 1. Persist for more than 3 months, may require more advanced interventions. 3. Often associated with underlying spinal degeneration. C. Bilateral sciatica affects both legs simultaneously, often linked to severe spinal conditions like Cuda Ecuna syndrome. D. Alternating sciatica. Pain shifts between leg. May indicate sacroiliac joint dysfunction or inflammatory conditions. E. Neurogenic versus somatic sciatica. 1. Neurogenic due to nerve root compression. 2. Somatic due to muscle or joint issues mimicking nerve pain. Causes. 1. Herniated disc. 2. Spinal stenosis, narrowing of spinal canal. 3. Degenerative disc disease. 4. Spondylolisthesis, slipping of vertebrae. 5. Trauma or injury to the spine. 6. Pyriformis syndrome. 7. Pregnancy due to pressure on the sciatic nerve. 8. Tumors or infections involving the spine. 9. Prolonged sitting or poor posture. Risk factors. 1. Age. Disc degeneration with age. 2. Obesity. 3. Sedentary lifestyle. 4. Occupations involving heavy lifting or twisting. 5. Diabetes can increase risk of nerve damage. 6. Smoking. 7. Poor posture or ergonomics. Complications. 1. Chronic pain. 2. Permanent nerve damage. 3. Loss of bowel or bladder control in severe cases like Cuda Ecuna syndrome. 4. Muscle weakness or atrophy. 5. Sleep disturbances. 6. Reduced mobility and quality of life. 7. Depression or anxiety due to chronic pain. Pathophysiology. Pathophysiology of sciatica step by step process. 1. Initial triggers. structural abnormality, a mechanical or structural issue occurs in the lumbar spine such as herniated disc, spinal stenosis, bone spur, or spondylolisthesis. 2. Nerve root compression or irritation. The structural abnormality causes compression or irritation of one or more spinal nerve roots, typically L4, L5, S1, S2, or S3. The roots that form the sciatic nerve. 3. Inflammatory response. Compression of the nerve root leads to localized inflammation, edema, and chemical irritation around the nerve, including the release of substances like prostaglandins and cytokines. 4. Nerve impulse disruption. Inflammation and compression disrupt the normal condition of nerve signals, causing abnormal pain signal to travel along the sciatic nerve pathway. 5. Radiating pain transmission. Pain, tingling, numbness, or weakness radiates from the lower back into the buttocks and the down the posterior aspects of the leg, following the course of the sciatic nerve. 6. Muscle and sensory impairment. Prolonged or severe compression can lead to muscle weakness, loss of reflexes, and sensory defects in the affected leg or foot. 7. Chronic changes if unresolved. Without treatment, long-term nerve compression can result in permanent nerve damage, chronic pain, or muscle atrophy. This cascade explains how a structural spinal issue ultimately results in the characteristic radiating pain and neurological symptoms of sciatica. Signs and symptoms. 1. Sharp shooting pain in the lower back, buttock, and leg. 2. Tingling or burning sensation down the leg. 3. Numbness in the affected leg or foot. 4. Muscle weakness in the leg or foot. 5. Pain worsens with sitting, sneezing or coughing. 6. Difficulty walking or standing for long periods. 7. Pain usually affects one side of the body. Diagnosis. A history taking and physical examination. 1. Pain description, onset, aggravating, relieving factors. 2. Straight leg raise, SLR test. 3. Neurological examination for reflexes, muscle strength and sensation. B. Imaging studies. 1. X-ray to check for bone abnormalities. 2. MRI, most accurate for identifying nerve root compression. 3. CT scan if MRI is contraindicated. 4. Electromyography, EMG, to evaluate nerve function. Nursing diagnosis. 1. Acute pain related to nerve compression. 2. Impaired physical mobility related to discomfort and pain. 3. Risk for injury related to sensory and motor deficit. 4. Deficient knowledge regarding condition and self-care. 5. Anxiety related to pain and reduced functional capacity. Medical management. 1. Analgesics, paracetamol, NSAIDs. 2. Muscle relaxants. 3. Oral corticosteroids, short term. 4. Gabapentin or pregabalin for nerve pain. 5. Epidural steroid injections. 6. Surgery, example discectomy, laminectomy if conservative methods fail. Nursing management. 1. Monitor pain and neurological status. 2. Educate about poor body mechanisms. 3. Encourage prescribed exercises and physical therapy. 4. Promote use of heat cold therapy. 5. Assist with mobility as needed. 6. Administer prescribed medications. 7. Provide emotional support and reassurance. Treatment options. A. Conservative. 1. Rest and activity modification. 2. Physical therapy. 3. Chiropractic care. 4. Pain medications. 5. Heat and cold application. B. Interventional. 1. Epidural steroid injections. 2. Nerve root blocks. C. Surgical. Microdiscectomy. 2. Laminectomy. 3. Spinal fusion in severe cases. Psychosocial medicine. 2. Cognitive behavioral therapy, CBT, helps manage chronic pain and reduce pain related anxiety. 2. Support groups encourage shared experiences and emotional coping. 3. Stress management techniques. induces meditation, breathing exercises, yoga. 4. Patient education increases understanding of condition, reducing fear and promoting adherence. 5. Vocational rehabilitation assist patients in modifying work environments or roles. Prevention 1. Maintain proper posture. 2. Engage in regular physical activity. 3. Strengthen core muscles. 4. Use ergonomically correct furniture. 5. Avoid prolonged sitting or heavy lifting. 6. Practice safe lifting techniques. 7. Maintain healthy body weight. 8. Avoid smoking. In conclusion, sciatica is a debilitating condition that can significantly impact a person's quality of life. However, with accurate diagnosis, early intervention, and a combination of medical, physical, and psychosocial treatments, most individuals experience relief from symptoms. Preventive strategies and lifestyle modifications play a key role in reducing recurrence and improving overall spine health. Thank you. Have a nice day.